I'm happy to have our guest today, Dr. Mi-Kyung Song, who is a professor in the Edith F. Honeycutt Chair in Nursing and the director of the Center for Nursing Excellence in Palliative Care at Emory University, Nell Hodgkin Woodruff School of Nursing. Dr. Song's research is focused on palliative and end-of-life care, including advanced care planning, treatment decision-making, family caregiving, symptoms, and family post-bereavement outcomes, with intense training in theory-guided intervention development and testing. She has led numerous NIH-funded intervention trials and investigations to improve end-of-life decision-making and family post-bereavement outcomes across patient populations. So please join me in welcoming Dr. Song to Columbia today for her presentation, Advanced Care Planning Research. Has it hit a dead end? Thank you. Dr. Song.
Thank you. Well, thank you so much. I'm, cut to the chase kind of person. So let's begin. I'm here to pose some important questions and open up a discussion. And somebody told me that the audience would be very vocal and actively participating. So I'm looking forward to it. Those of us who are particularly in the field of palliative care research may have been wondering, has advanced care planning research gone down to a dead end? Partly because there have been some editorial and Viewpoint papers authored by some of the leaders in the field. The first of those papers was published in 2004, entitled Enough: The Failure of the Living Will. This narrative reviews key points are most people don't have a living will, even with local and national initiatives and targeted interventions. And most people don't know what they want. And most people can't articulate what they want. And living wills are not accessible when they're needed. Proxies or surrogate decision makers often do not read it accurately. And also, these living wills are at times overwritten by proxies or clinicians at the end of life. They made these points with numerous empirical studies and very compelling. And rightfully so, the authors argue for no more living wills. Instead, we'd better focus on appointing a surrogate decision maker. I concur all of these points made by these authors. And then there is another editorial came out. By the way, humans have a strong tendency, which is trying to fix complex problems with a simple and often wrong or inadequate solution. But there are no simple solutions to complex problems. Now, in this case, trying to resolve challenges at the end of life care using advanced directives. In this editorial, advanced directives are equated with advanced care planning, which I find quite problematic. However, the good thing is that this article emphasized the importance of good conversations with the patients and their family members. Now, this year, a couple of months ago, JAMA published this Viewpoint article. You may recognize common names here, entitled What's Wrong with Advanced Care Planning? You notice the title doesn't include advanced directives now. The authors defined advanced care planning as a process to ensure goal-concordant care at the end of life and assert that advanced care planning does not improve end-of-life care, and that clinical and research communities should proceed with different needs and areas. Well, this is a prehistory, a little bat like a dinosaur that could glide, but only just. The feathered dinosaur was inept at gliding and incapable of powered flight. Flight is one of the wonders of evolution, but not every evolutionary journey ends with a falcon's speed. They were unlikely capable of flapping. Advanced care planning research doesn't seem to make a forward progress, particularly to the eyes of some people. But is a lack of a solution an indicator that the research is wrong or isn't worthwhile? To answer this question, I actually want to talk about the real problems in advanced care planning research. The first and most problematic is how advanced care planning is defined and operationalized in many research studies. That is narrow ACP, particularly when the definition of advanced care planning is limited to generating an advance directive or focusing only on documenting a patient's wishes. At the recent NINR Director's Lecture, I presented how I conceptualize advanced care planning and its outcomes by overlaying them with the chronic illness trajectory. The goal and the immediate outcome of advanced care planning should be focused on preparing the patient and the surrogate decision maker for end-of-life decision making. Without it, it is difficult to improve the end-of-life decision making experience and family bereavement outcomes after the patient's death. And I will demonstrate this a bit later. So what do I mean by preparedness? Decades of research in this field documented common manifestations of unpreparedness. The patients and their family members are unaware of the illness progression. It is difficult to see what's down the road. They would typically say they focus on one day at a time. And surrogates lack the intimate knowledge of patients' wishes. They often do not know what is acceptable to their loved one and what is not. And thirdly, surrogates are unprepared for decision-making during emotional turmoil, what it would be like to make critical decisions under a very stressful situation and often without much time. I shared this picture previously, and in this picture, a young girl is rehearsing for an upcoming performance. And just like that, advanced care planning should be an opportunity to provide the patient and family, and particularly for the surrogate decision maker, a mental rehearsal for end-of-life decision making. That's because research in psychology has shown that when emotionally distressed, people choose a default option as a coping mechanism, and their choice may have nothing to do with their preference. Now, it is no surprise that simply completing advance directives alone cannot improve patients' and family members' preparedness or end-of-life care outcomes. It's like providing a script to lay people and expect them to be prepared for the actual play and performance. The second problem is, in addition to equating advanced directive completion with advanced care planning, expecting the power that advanced directives alone could never have. There are so many multi-level factors at play when it comes to end-of-life care. And advanced directives at best may be able to address individual personal level factors that can rarely address institutional level or systematic factors, and such as access to care. End-of-life care is complex and messy. It is like an English truffle, encompassing layers of a patient, family, and provider communication, cultural values and preferences, access to care, and systemic biases, and so on. The expectation for advanced care planning such that it is to ensure goal concordant care near the end of life is simply unrealistic, ignoring the decades of research on end-of-life care. The chronic illness model is one of the well accepted in chronic illness management and has served as a conceptual framework for many intervention studies. The CCM identifies the essential elements of a healthcare system that encourage high quality chronic disease care. Patient level factors are included here, but they are only part of the factors affecting outcomes. Improving end-of-life care is not any different. This is a model of a diabetes care. It depicts factors affecting diabetes care where multi-level factors interplay. Similarly, according to the social ecological model of health, there are many factors that can influence one's health. End-of-life care is not any different. We know that there are many factors are at play. The third problem is related to problems 1 and 2. That is, when advanced care planning interventions aim to engage patients and families, although often patients alone without family members, in completing an advance directive or even having a discussion, investigators often expect the completion of advance directive to influence so many other outcomes. This is a round hole and square peg phenomenon that still continues today. So for example, as an outcome, advance directive completion rate. Now, this is a part of the advanced care planning process, and as such, it is not a real outcome of advanced care planning. What about improving patient or family members' quality of life? What is the underlying mechanism of this? Now, the next one is even more interesting. How on earth having an advance directive can improve quality of communication between patient or family and clinician? Did the intervention involve training patients or family members how to talk to clinicians? Now, satisfaction with care is another outcome that completely throws me away. What is the assumption underneath? What about palliative care use or hospice use near the end of life? And what if the patient's preference was to undergo aggressive interventions no matter what? What about access to patient or hospice care? So how would advance directives or even an in-depth discussion about future medical care address those barriers? And of course, there is the outcome of goal concordant care. I have a lot to talk about this. So measuring goal concordant care is never straightforward. Years back, my team and I demonstrated how challenging and messy this is. And typically, investigators would rely on the patient's medical record to abstract whether there was written documentation of the patient's preferences for goals of care. And they would also abstract the documentation of medical care or any procedures, interventions near the end of life. Consider this case. This appears to be quite straightforward. The patient had an advance directive before, and his or her preferences for end-of-life care were known. The patient develops a serious acute illness or went into hospital for planned medical procedure, but quickly develops serious complications. So his or her condition quickly leads to end of life, and then the patient dies. Now, in this case, the common determination would be looking at the consistency between the patient's last written goals of care and end-of-life care the patient received. But in our spirit trials, which we'll talk about a little bit later, we observed a variety of situations that make such a determination extremely difficult. We traced the multiple documentations of a patient's goals of care preferences. And also a sizable number of patients died suddenly. Now, in those cases, what would be most appropriate ways to handle them? Should we simply exclude them from the analysis because there were no end-of-life care? But what should be considered end-of-life care? And what about the situations where the patient was able to participate in treatment decision-making until very close to a death, which is not uncommon. The in-the-moment decision may be different from the previously expressed wishes, and this may or may not be clearly documented in the medical record. So in the cases where the surrogate made decisions with the patient as they actually face end of life, this can lead to 4 additional possibilities of consistency determination. And one is consistency between the patient's decisions at the end of life and his or her last written goals of care preference. You could also compare the patient's decisions at the end of life and the surrogate's decision. Another possibility is comparing the patient's decisions at the end of life and the care the patient received near end of life. And finally, the patient's last written goals of care preferences and the surrogate's decision. So there you have it, the messy business of determining goal concordant care. The 4th problem is that often the role of a prognostic information in advanced care planning discussions is exaggerated. Too much focus on prognostication and providing prognostic estimate. Now, the assumption here is that if patients and or family members are aware of more accurate prognostic information about the likelihood of illness progression or survival, they would likely consider less aggressive treatment for future medical care. For example, in the case of end-stage renal disease, patients may consider stopping dialysis and choose hospice care. I think this assumption reflects the lack of understanding of human psychology. In fact, systematic reviews across various patient populations, including cancer, have consistently shown that there is little to no positive association between prognostic communication, however individualized it might be, and the discussion of care preferences or a certain treatment choice. People need an opportunity to reflect upon their illness experience instead of prognostic estimate alone. Well, let's take a look at these 2 pictures. In this picture on the left, you are in the woods. You can see a few feet before you, but you cannot see what's down the road after that. Patients with multiple chronic conditions and their family members often say they take or focus on one day at a time. In the picture on the right, you have a bird's eye view. You see ups and downs and twists and turns. And this is more like a clinician's perspective when it comes to illness trajectory. The differences between the 2 cannot be addressed by simply delivering prognostic information. The 5th problem is the timing is often too late. This is a case where the end-of-life discussion becomes goals of care discussion as opposed to advanced care planning because it happened too late and close to the end of life. The examples are there. I can talk about is there are 3 large clinical trials that were set in the ICU care setting. Now, in the ICU, family meetings are where goals of care discussion happens and the family members are asked to decide whether to stop or continue life-sustaining treatment. Now, these clinical trials of ICU interventions had a common goal. which was to help family surrogate decision makers in end-of-life decision-making for their loved ones so that intensive procedures and ICU length of stay and the post-bereavement distress can be reduced. Now, unfortunately, all three studies achieved null findings in improving family decision makers' hospital anxiety and depression scale scores after the patient's death. To clarify, I do think that interventions to support ICU family decision makers are necessary and important. But the issue here is that the timing of these interventions is already near the end of life. Given the fact that most Americans do not engage in advanced care planning process, here what I mean by is the one involving an in-depth discussion. And those family members walk into the end-of-life decision-making situation without any preparation. This is another use of a metaphor for advanced care planning, and one that can soften the impact of the actual decision-making at the end of life. End-of-life decision-making in the ICU without appropriate prior advanced care planning is like this. Family decision makers are already soaked in rain or crisis, and it is difficult to reduce the impact of trauma. So the spirit intervention, sharing patients' illness representations to increase trust, is an approach to preparing patients and families for end-of-life decision-making. In Spirit, a clinician uses a theory-based structured intervention guide, which includes prescribed questions that the clinician must explore with the patient and the surrogate to make the discussion effective. It targets both patients and surrogates as it aims at preparedness and not completion of a document. It is a face-to-face meeting format and designed for outpatient care setting. These sessions are conducted along the 6 steps based on its theoretical underpinnings. Step 1 is assessing patient and surrogate's illness representations and asking both the patient and the surrogate about how the patient's illness has affected life, for example. Now, this first step is the most important step of all because it creates a foundation for the next steps and naturally leads to later steps to discuss likely end-of-life situations. In our previous efficacy trial that involved 210 diets of patients with end-stage renal disease and their chosen surrogates, we evaluated the intervention effects on operationalized preparedness outcomes and also the surrogate's post-bereavement outcomes after the patient's death. Here, the intervention group showed a significantly higher number of diets who were congruent in goals of care at the end of life, and lower patients' decision on conflict, higher surrogate decision-making confidence, and the composite variable that indicates that surrogates had the intimate knowledge of patients' wishes and were confident in their role as a surrogate. So Spirit helped the diets prepare for end-of-life decision-making. But the effects of the intervention on post-bereavement outcomes are much more encouraging. The anxiety, depression, and post-traumatic stress symptom scores increased shortly after the patient's death, understandably so. But then intervention family members' symptom scores returned to baseline by 3 months, while the control scores remain higher. That is, the Spirit helped the families move on with their life instead of ruminating and wondering, did I do the right thing? The qualitative interview data revealed how the Spirit intervention might have affected the end-of-life decision-making experience and improved the post-bereavement outcomes. This graph shows the percentage of surrogates by 4 major themes from the data. Many Black surrogates perceive that the spirit helped them prepare for end-of-life decision-making and actually made the decision-making easier when the time came. In contrast, a higher percentage of white surrogates reported that spirit was an eye-opening experience in that they got to know their loved ones, how their loved one felt about the illness, dialysis, and life-sustaining treatment, and their relationship got stronger after participating in the spirit intervention. These data demonstrate that the experiences of the spirit were very much of intra and interpersonal affairs. So when I shared these data with some of my colleagues, and they said, well, those are soft outcomes, as if these are not as important or a lower level of outcomes or not matter much, but matter to whom? In our ongoing phase 3 trials of the spirit, we are looking at whether spirit will achieve the similar levels of effectiveness when it is rolled out to a real world with less control over the intervention delivery. And we are also collecting implementation data. We are on the final year, by the way. In this trial, we worked with the participating institutions' healthcare systems to make the summary document available after each spirit intervention. And those documents would be uploaded to the patient's electronic health record. And I want to tell you a story of one of our spirit participants. A patient who has been on dialysis for more than 15 years participated in the trial. Because he didn't have a spouse or any close family members, he appointed his niece as his surrogate decision maker. So he and his niece participated in a spirit session conducted by his dialysis social worker at Emory Dialysis Center. During the spirit session, he became clear about his preferences for comfort care if his medical condition gets worse, to a point where his recovery from an acute illness, for example, and then maintaining quality of life is very unlikely. So niece was willing to follow through his wishes. And this is a summary of the discussion documenting his wishes and his designation of niece as his surrogate decision maker was uploaded to the dialysis medical record and Emory healthcare system. Last year, he visited Michigan and came back with COVID. His condition rapidly deteriorated and was taken to the ER. A niece was with him. As the ER doctor thought his recovery would be very unlikely, but he was going to order aggressive interventions anyway to prolong his life, niece stopped him and said that it wouldn't be her uncle's wish. But ER doctor questioned her about her authority to speak for the patient. So niece told him that she and her uncle participated in a spirit session. And his wishes were documented, and including her being his surrogate. Thankfully, the ER doctor called the dialysis clinic social worker, and the social worker confirmed that what the niece told the doctor was true and pointed out where the summary document was located. So ER doctor pulled the document and then followed the direction. In the end, the patient was sent home for his final moment with niece and other relatives and friends. So you see, there are many components and factors to honor the patient's wishes. Any of those could fall into the cracks, and which are beyond the completion of an advance directive or even the spirit session. I don't think we can walk away from addressing the need for preparing patients with chronic illnesses and their family members for end-of-life decision-making. Still, many family members go through traumatic end-of-life decision-making experiences and its consequences. Have you seen these study reports, by the way? The clinical guidelines by the American Society of Clinical Oncology and the National Quality Forum discourage aggressive, invasive, and expensive medical services or interventions that represent low value care at the end of life. But study after study such as these have documented that many patients with metastatic cancer continue to receive aggressive medical interventions throughout their final months or even weeks of life. And this trend is much worse in racial ethnic minority groups. How can we possibly address this issue without involving patients and family members and discussing and helping them understand the nature of those medical interventions near the end of life? That's exactly what advanced care planning should be. Can we move on to other things to study because advanced care planning doesn't seem to improve end-of-life care? So instead of calling for moving away from advanced care planning research altogether, I think we need to be clear-eyed and understand what the real problems are. We need to regain sight of the essence of the problems that need to be solved and the questions that need answers. What we need to move away from is hoping for addressing a multi-layered and multifactorial problem with an intervention targeting patient and or family only. We need to move away from poorly conceptualized studies, move away from a round hole and square peg research. We need a deeper and more sophisticated understandings and inquiries to improve end-of-life care. I think that includes perhaps moving toward the research to address multi-factors. Now, patients and families are necessary players, but we know now more than ever that there are other powerful factors that can affect the course of end-of-life care. But studies to address those other factors or multi-factors are harder to design and harder to conduct. But we need to move toward that direction. And I also want to advocate a more careful and studied choice of research questions. And please, no more studies focused on advanced directives. Thank you.
Well, thank you. Time for questions. People have some questions here. Very thought-provoking.
Mi-Kyung, I'm sorry I was late. I had a small procedure that I had to do. But I'm glad I got to come in afterwards. So you said that other factors will the multi-factors, if it's not just advanced care planning, the other factors to improve end of life.
We're losing you, Pat.
Yeah, I couldn't hear all sentences.
You're in and out, Pat. You might want to type your question in the chat. Anybody else have one while we wait for Pat to type in?
Yeah, Dr. Song, this is wonderful. It's really provoking. So my question is related to the slides you showed, the impact of the Spirit program on the white and Black patients.
Mm-hmm.
If you can pull back that slice, it's very interesting to see. It looks like one group has more, think the intervention is more. I don't remember exactly the word. Is more eye-opening, but in the end, the impact on their decision making is less significant than the other group. So I was wondering how have you looked at the, yeah, so the was eye opening and the white. And
yes, I think the white folks, their perceived impact of a spirit were more about gaining insight and knowledge, learning more about their loved ones' perspectives than actual end-of-life decision-making itself. And we found it actually quite interesting. So I think toward the end of your question, I think you were trying to ask about whether there was any racial differences in terms of the outcomes.
Yeah, so it looks like the white perceive the intervention is better, but exactly the
actually Black folks, they perceive the spirit intervention helpful to prepare for end-of-life decision-making compared to white
I see.
folks. So
okay.
we actually looked at the spirit trial outcomes by race. In this particular trial, we included only two racial groups, and whites and Blacks. And in fact, the effect size of all these study outcomes, including the family members' bereavement outcomes, were much greater in African Americans.
Okay, that's wonderful. Thank you. I think Pat's question.
So I don't know, can you hear me now? I was just wondering what you thought the next multiple factors were that you'd like to study, you know?
Yes, I mean, I think there are a couple of things. If in fact the intervention is targeting patient or family level, then I think the outcomes should match. It's one thing. The second thing is I'm moving toward a more system level factor to address those barriers. It's much harder, I have to admit, but I don't think we can improve or end of life care without going much next level. So I mean,
how would you think about improving the system level factors? I'm asking because I'm in the process of writing a grant around health disparity, hospice use in nursing homes, and it seems like it's a system level factor. So, you know, because it's underused. But I'm just wondering, like, how can we improve these system level factors?
So for even the simple as like making this a summary document available in the healthcare systems, we had to go through many hurdles, and the approach to making it happen had to be tailored to individual health systems, and so we had a lot of meetings even just for that simple goal, and work with those gatekeepers and stakeholders, if you will, and figure out what would be most appropriate ways to make it happen. So that would be one example. And we also had a lot of meetings to identify what would be the institution or hospitals or even dialysis clinic specific barriers. So we are brainstorming with the folks at individual healthcare system and the clinics, so that meetings would involve managers and then high level leadership, as well as those social workers and nurses and nephrologists.
Thank you so much. I think there's another question in the chat too from Maria Teresa.
I have a question too.
Okay. Let's do this one first in the chat. What would you recommend in terms of hospitals being asked to document quality metrics in the completion of advanced directives, advanced care planning completion, and most completion?
Okay. Yes, I mean, it's interesting. I mean, if you look at years back, even making it part of the quality metrics, that was a huge accomplishment. And now we are saying that metrics, may not be actually reflecting the real quality. And in fact, that drives a lot of people to even more focusing on these documentation rather than really having good conversations. And so it's hard to address this question actually. And I do personally think that we are experiencing the side effect of these initial initiatives.
I have some questions. Thank you, Dr. Song. This was very thought-provoking and very interesting. And when you talked about that individual, the participant who had participated in the spirit trial and then had the COVID and went into the ED, and the ED doctor wanted to pursue an aggressive treatment, and then the niece was available for that participant, that patient, and then was able to gain that documentation summary. And I think that's the whole system level factor that needs to be incorporated in the advanced care planning. But my question is about, so you had mentioned about how you are currently conducting a study looking at implementation outcomes related to spirit trial. And I kind of wanted to learn more about that and whether you can share with us a little bit more about the results and how can the spirit be implemented in the real world setting? Because, as you were mentioning, there are many system level barriers and that need to be addressed, and I'm sure you had come across that. And my other question is were there any participant within the spirit trial that lacked surrogate decision maker, and if so, how and what sort of things happened to these individuals who lacked surrogate decision maker to have to determine to have a decision maker for them? And lastly, I'm sorry for the many questions, when would be the right timing for advanced care planning?
Those are great questions, Mocha. The first question about the implementation outcomes, and actually we didn't test any implementation strategies. So we are, when I mentioned about implementation, it was gathering implementation data. Which may help selecting or even working on the implementation strategies for future use. We have come across a lot of challenges, and currently this intervention is being delivered as part of a routine dialysis care, which requires a tremendous coordination and working with the dialysis social workers and the nurses and the nurse practitioners, and all together. It really requires a whole village to carry it out. I just finished another set of spirit training with our control clinics, and fitting that spirit intervention into their workflow, it's still very challenging. Now, originally, this spirit intervention takes about 3-day intensive training, and I streamlined into 1-day training, and that was challenging. This time, I'm giving the spirit champions or social workers and the nurses a lot of leeway in terms of how they deliver this intervention. As long as they stick with the intervention guide, and that is the one bottom line standard measure to maintain certain quality across the board. Because study after study, we learned that as long as you use those questions, meaning ask those questions as directed, prescribed, then you will accomplish something. And that was, to me, very clear. So other than that, that's the core element that I wouldn't want them to change. But otherwise, in terms of a format, and other things, I gave them a lot of leeway. And that was important because social workers, particularly, it's their part of the practice addressing end-of-life issues. So I wanted to respect that. During this trial, over the course of 4 years, a lot of staff turnovers and then pandemic hit. And going through that challenge and still delivering this spirit intervention, part of their routine dialysis care, we faced tremendous challenges. Mm-hmm. And the only thing that we could get through was that having conversation with these community partners and understanding their challenges, and they understand that the mission of the whole this thing. And that's the only way that we could get through it. And now the control clinics, they've been serving as a control group, and those champions are on board, and they just trained, and they need to practice and be certified, and they will start delivering this intervention for their own patients. Now, the second question related to lack of surrogate, it is our ongoing problem. And whether the patient has no living one on earth who can speak for the patient, that's one issue. Another is there are surrogates available, family members available, but somehow they are unwilling but unable to serve as a surrogate decision makers. In our field, this particular challenge has been discussed, but we don't know, actually. We don't have any good solutions how to address this. Now, the lack of surrogate or any living person who can speak for the patient, now those patients are called unrepresented patients. And in the field of ethics and law, they are trying to address that how to honor these people's preferences, and particularly preferences are unknown and no surrogates available. So at this point, I don't have any answer to this question. Now, third one, timing is we often say early, having this conversation early, and that's better. What does early means? I would say it's today. So it's not early. Some people say at the time of diagnosis of any major illness and serious illness, I don't think that's necessarily a great timing, but it is basically today. And so that those conversations would not happen first time during ICU stay.
Thank you.
Hi, this is Marlene McHugh. I'm sorry, I'm driving. Can you hear me?
Yes.
This was a wonderful talk. I really enjoyed it. I work at Montefiore in the Bronx, and we've had major system initiatives in terms of advanced care planning over the years. And what I really like that you said is that you involved the social workers and the nurses. And I think that this has been one of the pieces that everyone is starting to figure out, that the primary care providers who have the longest relationships with patients don't have the time. There was recently a qualitative study put out from the Montefiore Primary Care Group about advanced care planning and referenced some of this. The one thing that I think is a barrier that I've come across is that in terms of talking about trajectory of illness, practitioners and providers who don't have that experience with caring for an illness over time are very uncomfortable having this conversation. And I think this raises a lot of questions in terms of looking at nurse practitioner training as we move forward. We train in acute and primary, but we don't train across settings. And we really need to be thinking about that, because the picture is not just a snapshot of the patient in front of you. It's this trajectory of illness.
Right.
And we have to get a younger population of nurse practitioners who may not have acute care training comfortable with these conversations. So I think that's a point we have to keep in our mind as we move forward.
Yes, I appreciate your comment. This part of this the spirit intervention, what's embedded here is a clinician training. Although what is tested is not about the training whole package, but you can't separate training from this kind of intervention. Now, the level of comfort in conducting this kind of conversation does require training. It is one of those skill sets, and anyone can be trained. So to lift some of the burdens on the part of these clinicians conducting this challenging conversation is to provide, is the intervention guide. So that is, that definitely reduces the burden and the discomfort when they need to have this conversation. Now, the intimate knowledge of a patient's illness trajectory and where the patient has been, I don't think it's a necessary component conducting this discussion based on my experience, because none of the spirit interventionists in the past, and even these dialysis social workers and nurse practitioners, they don't necessarily know all the trajectories and intimate knowledge of patients' illness condition. But what is necessary is asking the right questions so that patients and family members can think about themselves and reflect upon. That's what is necessary. So I think that those two things are different, but then the people typically think that, well, it's better to have this conversation by someone who knows the patient's family members well.
I agree.
And also the illness trajectory, it may or may not be. But my experience throughout having this spirit intervention with almost now is 800 patients and surrogate decision makers, we didn't know anybody and their intimate and any intimate level and even their medical conditions. The information should come from the patient and family members, and that process involves reflection, and that's what is important.
Thank you, Ms.
Thanks.
There's also May Hua has a question for you. It says,
Hi, May.
Hi, nice to see you. I can ask it. I just didn't know if I would get a chance. Sorry. So you spoke a little about the need to have this high quality conversation to have a chance to really move outcomes as a result of an ACP type conversation. So can you speak a little bit about your thoughts on how you might measure there being a high quality conversation? Are there certain elements that you're looking for that you start to think about the document?
So early on, the qualitative communication, that was part of the outcome, because there was interventionist, conducting this discussion, and we measured some of the components of the quality that conversation make more high quality, and that is the first one, the illness exploring and trying to understand the patient's life with living with a chronic illness. And also the exploration, even simply asking them about how the illness has affected their life, and both physically and emotionally. And also asking family members their experiences and the emotional representations as well. And every time, and then we also came up with a coding schema to add more third person's evaluation of the quality of communication. And majority of them has to do with how to address the emotional piece. And that was important. And that's why the training includes how to respond to those emotional reactions. And that was one of the major training areas. Any other questions? Thanks for wonderful questions, by the way.
Thanks for a wonderful talk. It was really great. So thanks again.
Thank you. Thank you. I hope Sean Morrison wouldn't feel offended. I know he's one of the external advisory board members.
He won't, no. Thanks a lot. And I'm looking forward to talking to you in a couple of days.
Thank you. And nice meeting you all. Thank you.
Thank you. Great job.